Since
Dr. Guadalupe?
here. All right, at this time, we will open it up to any public comment.
We do not have any public comment this evening. I do want to remind people that if they would choose to submit public comment, they can do so either through our website or they can type their remarks in the chat, and we will read them later on at our second opportunity, and people receive the responses from the customer services team.
Thank you, Christine.
I also don't have anybody in the room that's public comment either. I guess
Great, thank you, Sheila. All right, we will move on to our first item, our new board member introduction by Jonathan Lansman.
Good evening, everyone. I just wanted to take a moment and welcome Dennis to the board. He and I had a chance to talk this morning briefly because of our schedules, but I think he's going to be a great addition to our board. It's coming from Royal Oak, having served there in the public eye for many years, both as a city council and I believe as the mayor. And he has someone in his family that receives services, his son, who's an adult, who's receiving services at this point. As well, I'm just glad that the county has seen fit to appoint him and renew Dr. Hahn, Dr. Taub, and our secretary, Adam Furman. So with that, I just wanted to quickly say welcome, Dennis, and we look forward to still maintaining the social distance, but being able to do the face-to-face calls as we can. Thank you. Is there anything you would like to say as you're stepping onto the board?
Well, it's a mistake to give a reformed politician a microphone. No, but thank you for your generous welcome, and I look forward to serving on the board. I have a lot to learn, and I hope to learn from everybody on the board and the organization, and I'm very pleased to be part of this great organization serving the residents of Oakland County. Thank you.
All right, thank you. And I'll turn the floor back over to you, Sarah.
All right, thank you. We are going to move on with our COVID-19 year review with Dana and Dr. Lawson.
Good evening, everybody. I hope you can hear me okay with this mask on. We thought it was very important that we give you an overview, our year-to-date review of the outcomes as it relates to COVID and the response that we had. Well, prior to me being a part of the team, 6 months in, the team here at OCHN, the executive leadership team, put in some programs and services in place to make sure that the people we serve remain safe. So we did want to report to you some of the data that we've been looking at for the last year and some of the outcomes. So I'm going to start with the demographic piece, and then Nicole will talk about the service utilization. So the first slide demonstrates to you the number of positive cases since March 2020. We had 541 people that actually tested positive for COVID. And so you do see the breakdown of the people served and the population designation. The next slide talks about lives lost. And so as of March 10th to current date, we have 36 reported lives lost. 18 of those individuals were individuals diagnosed with an intellectual or developmental disability, and 17 were with MI, and there was one individual who was not designated or identified to a population served. So, of course, the rate is slower than the general population in Oakland, but we did think it was important to talk about that and the things that we did to keep people safe. Overall, the breakdown of the demographics in terms of age, 69% of the folks, age, they were broken down, as you can tell. There were 13 people who were 70 to 79, 10, 60 to 69, and therefore it does represent the general population in terms of people in their age ranges that were impacted by COVID. 69% of the individuals that were reported were white, 17% of the individuals were Black or African American, 8% were identified as other race, and 6% did not report. So vaccines, which we're very proud to talk about. So in the last month and a half, we did our effort and joined with the community and working with partnerships with Honor Health as well as Genoa Pharmacy, and we did have vaccine clinics. And so to date, these aren't the people that we actually vaccinated. I believe they are, right? No, okay. These are reported vaccines, but we played a big part in it. So we had a total of 2,855 people who received a vaccine. 2,778 received at least one dose of the vaccine, and 1,592 people were fully vaccinated. So just in terms of people served, we know that's not everybody we serve, and we are also focusing on the community for SUD. We see a lot of resistance or anxiety about becoming vaccinated in that community. So we're looking at efforts outside of the norm to see if we can find ways to tell people and educate them about the vaccine and how to access that. So part of what we did in the beginning of the COVID pandemic was we identified a place for people to go who were testing positive and could not remain in their home. So we had a unit at Pontiac General Hospital where people could receive supports with their staff. A total of 9 people we serve actually utilize that service. We also identify hotel rooms for staff members who could not go home and infect their families. So we had 71 staff that actually took advantage of that program. So the last part of the presentation is just a general overview of the data that I just went over. So I'll pass it over to Nicole.
I think you're muted, Nicole.
Okay, there we go. Thank you, Dana. Good evening, everybody. So I'm going to go over some of the network service utilization because it was really important for us to also, in addition to keeping people safe, make sure that services and supports continue to be delivered even throughout the pandemic. So if we look at our first slide, we're going to see the utilization trends for crisis residential units as well as inpatient and partial hospitalizations. So we did see a slight increase in use for both of those services. There was an 8% increase in the use of crisis residential unit. In FY20, a total of 834 people used that service as compared to 775 in fiscal year 19. And we also saw a 6% increase in our inpatient and partial hospitalization utilization. Our next slide shows the number of people who went to Common Ground over at the Resource and Crisis Center for crisis intervention services. And you can see the decline in March followed by the big drop in April. And that's a direct impact of the beginning of the pandemic. We were really happy to see that people did begin to utilize that resource as things progressed and as our positive case rates started going down. If you follow the gray line, which is on the left of that graph and represents this current fiscal year, you'll see that there are some dips in utilization. We can attribute those to increased COVID positivity rates. So it's a fair statement that when positivity rates are at their highest, people are more reluctant to seek in-person services. And we'll see as we go through the slide that that's a pretty general trend that we see throughout all of our supports and services. Our next slide, we track the number of people seeking services at an emergency room or an emergency department for behavioral health reasons. We did exclude medical reasons from this data set. And it appears that those seeking behavioral health supports at an emergency department follow the same general trajectory as those seeking supports at the RCC. The good news here is that it does appear that after an initial spike in the summer, once the stay-home order was lifted, people seeking that type of support for behavioral health reasons has declined steadily, which is good. We want them calling their provider. We want them going to the RCC, not necessarily to an emergency room. You will see that there's that sharp decline around February, and that's just indicative of the data lag that we experience. when we use that adjudicated Medicaid claims Care Connect 360 database. So this next slide shows people new to services. So you'll see again a very sharp decline at the beginning of the pandemic, and then we saw people start to seek services again towards the end of the stay-home order. We are seeing that current new admissions into services are very close to those pre-pandemic. So we were happy to see that people who need services are back to seeking them the way they were pre-pandemic. And then this next slide demonstrates the most frequently used services that we had in our network that supports people with substance use disorders. And then the next slide shows the actual provision of supports and services over time. And we wanted to analyze the impact of the pandemic both in general terms as well as in the relation to the use of telehealth services. So you can see in that graph that the vast majority of services in our SUD network remained in person, even throughout the course of the stay-home order last year. And the next slide shows the most utilized services across all of our other behavioral health providers. So I just wanted to note that these are intended for a high-level overview. I will get into specific networks in just a couple slides. So in looking at the overall trends, we really noted that while people new to services dropped significantly during the stay-home order, our providers were serving slightly more people overall. So what we're inferring from that is our network really did a stellar job of engaging those people who were currently enrolled in services to make sure that they had ongoing support throughout the course of the pandemic. And the next slide takes us through each individual behavioral health network. And we are starting with our network that serves people with intellectual and developmental disabilities. So here you'll see that familiar trend in the drop of face-to-face services during the pandemic and when we had higher positivity rates in the fall. We'll also note that less than 3% of the services provided in this network were provided via telehealth versus 97% in person. So when we look at this data, one of the things that we think maybe the reason behind that is that most people served in this network receive more CLS and or respite services than any other service. And since those can't be delivered via telehealth, it makes sense that 97% of those services were delivered in person. And our next slide looks at the services for adults with mental illness, and we can definitely see more use of telehealth here. We have about 51% in person as opposed to 49% telehealth utilization for this network. And again, you can see that clear trend that when positivity rates go up, so does telehealth services. And then we have our network for youth with serious emotional disturbance, and it shows similar trends to our adult network. There's slight more use of telehealth here at 54%, but that familiar pattern of increased telehealth being directly correlated into increased COVID positivity rates. So as we wrap up, I just wanted to take a moment and really thank our providers for their adaptability and ongoing service provision based on choice throughout the pandemic. Dana and I have been on many calls where Mdhhs has made several statements related to ensuring that people are given choice and that they get in-person, face-to-face services where they want to. They cited concerns that many other CMHs around the state were only willing to provide telehealth. We can appreciate the balance that providers have had to strike to implement safety for both the people that they serve as well as their staff, and we were just really, really proud when we saw this data. So with that, are there any questions?
Hi. I've got three things. One's a question, one's a concern, and then the other one is a way to go. So I'm interested in learning more about resistance from the SUD community. Today's meeting may not be the place to to get more information, but I would appreciate if I could have conversations with somebody at some point to understand that. I mean, I understand in the disease that people, tend to make up their, you can't tell them anything. I mean, as a person in recovery, you can't tell me anything. I know more than anybody else. You know, just ask me. But then on the other hand, in a 12-step program, we are, you know, there are things that we are supposed to do that would that I think would have people comply. You know, anyway, so I find that interesting. Although the group that my home group, you know, the people there, most of the people weren't interested in getting the vaccination. So, anyway, the second thing is, I noticed that with substance use, the use of drugs and alcohol has been on the rise. I believe that I saw a report from the state of Michigan that said that the amount of alcohol consumed over the past year during COVID has risen. I don't remember if it was dramatically or slightly, but it had risen. But then the utilization of services is declining. And so the concern is that as we get out of the pandemic, are we going to start to see, I mean, you would think that we would start to see very rapid increase in utilization of SUD services. And then the last thing is, the one thing that I think was absolutely amazing for the staff is that they looked forward and they worked hard to get hotel room stays for employees that were concerned that they were at work and they may have been exposed to COVID, yet they didn't. We were able to provide hotel rooms so that they didn't risk their family getting COVID and possibly dying. And I just want to say such a big thank you to the staff for doing that, because that was all happening right when, you know, I don't know if we all remember exactly how scary it was right at the beginning. And to give a worker an option not to get their family sick, I just think is amazing. And I'm so glad that the staff saw that was a need early on and did what they could.
Yeah, the only thing I would add to that is that there were a substantial number of those individuals who were protecting the people they served. They were worried that their household members and others were also exposed, and they didn't want to bring that to the vulnerable individuals that they served. So, you know, the direct support professionals in this network were beyond heroic. I don't know of a word to describe their actions throughout the course of this pandemic.
I have a question. This report then, this runs for the year covering COVID, then basically March to March? Okay. With some data lag. Yeah, I noticed. Yeah, some data lag.
Some data lag.
Give or take, it's roughly a year. Okay. And then, according to the numbers, then we could say that approximately half of our recipients are fully vaccinated. Then is that what I saw, or was it, or received at least one vaccination?
I think it's definitely less than half, and those are the numbers of people that have received a shot, or the vaccine, at least one dosage of the vaccine.
Yeah, one dosage.
But we serve over 23,000 people a year, so that's not enough people. And this is just based on a Mdhhs report, and that's where we get our vaccine data from, through the state. So there may be other people that we serve that have had the vaccine, but we can't identify them directly, and there is no self-report of that.
Okay. And then the other number that I saw that was kind of eye-opening was the race distribution.
Yeah.
Where it was 17% Black or African American, and then 8% identified as other race. So we could deduce from that 25% of the population that doesn't identify as white has been affected.
Yes.
Wow, which is staggering. And the other one I had a question about was the substance use services. I think the number for, was it the methadone? It was extremely high. Sorry, I had that slide here a moment ago. Yeah, substance use disorders, network service utilization, highly utilized services. So, methadone administration and/or services for the substance use disorder was at nearly 70% of that population.
So yes, of all of the services, so the unique thing with medication-assisted treatment is that it is a daily service. So the vast majority of people would not necessarily engage in the rest of those services on a daily basis, which is why it looks so much higher.
Okay.
Yeah,
So
you might go to therapy, I mean, once a week, maybe
Right.
twice a month,
that makes
versus
sense. Then.
you're going in every day to dose for MAT.
Okay. Yeah, I was wondering why that number was so high. So that would make sense. So those are daily services for the methadone.
Yeah.
Okay. All right. Thank you.
Is there anyone attending remotely that had any questions for Dana or Dr. Lawson?
This is Hadass, I do, actually.
Okay.
Oh, I guess for me, it sounds like I'm an echo, but that's okay. So I actually want to reiterate what Eric was asking. I had concern and understanding that people with SUD or anxiety may not want to take the vaccine, and obviously you've done a great job, and this is a great example of what happened this year, but the concern is being active and concerned about what's going to happen in the next year. So if there's a committee at OCHN, or if a board members that are interested in this support want to be on that committee, like we are for recipient rights or purchasing committee, I almost feel like it's so important. Perhaps John might want to consider an ad hoc committee to support an education of the vaccine. So that's something I just wanted to bring up.
May I comment on that? This is Dana.
Sure.
The other thing, we have the SUD Oversight Policy Board, and internally, we're also looking at other options as in terms of getting the information out. And we actually had 2 providers in the SUD community reach out to us about having a clinic on site where we could go, or would our partners go to the actual service site and provide vaccinations for people. So I think the word is getting out. I just think we need to reach out to that community more aggressively. And we're also looking at options as it relates with our new Chief Medical Officer, Dr. Posio, as it relates to providing mobile clinic services. So we're looking at how we can go to those communities and those provider sites to offer the vaccine to the folks that are there, instead of waiting for them to come to us. So we want to make ourselves available. We're just pulling those things together now.
Well, that's great to hear, and if you can keep us posted, then that would be much appreciated, so thank you.
Absolutely.
I didn't have a question, but I did have a comment concerning the vaccines. First of all, I want to thank OCHN for the tremendous effort that the staff has put into volunteering, to making sure that people who want to get the vaccines can. A CNS was involved in one of the clinics, and when I found out about it, it was on Friday. So that whole weekend, we had staff that was calling, texting, sending out information through Facebook. One of the things that's really impactful to me is that the resistance is starting to come down amongst populations that before now didn't want to take the vaccine. I was one. I've been on board meetings in tears, definitely afraid. I've had both of my shots now, and I'm glad that I did it. My daughter was dead set against it. She just got her Johnson & Johnson, her and her husband, last weekend. So I think as more and more people let it be known that they have taken the vaccine, what the effects were on them, because I talked to somebody in particular, they said, I don't know who to trust. I said, well, Trust people that you know. Forget about Facebook. Forget about, you know, trying to figure it out in the news and all of that. Talk to your medical professionals. Talk to people that you know that you can trust and get your information from those sources. And I think the more that we talk about it, the more, and having the foresight to make it available to people who do not have internet access. That's been huge. Honor's been doing a fantastic job of working with the churches and other organizations in Pontiac and outside of Pontiac to make sure that people who couldn't get online to get registered could still get vaccines. I volunteered to help with that effort as well. Now I'm becoming the vaccine guru. I got people calling me on Saturday, I need a shot. 9:30 at night, can I get a shot? You know, but it's a worthy cause. I'm so glad to be able to do it, but my hat is off to the professionals that are making this possible. So hats off to Honor. It's near and dear to our hearts because that's our baby. We started that, and looking at what they're doing now is just phenomenal. But I also want to highly commend the staff here at OCHN for all of the hard work that you're doing with the clinics, making sure the people who are on the list get the shots. And I've heard nothing but good things from people who've come in here to get their shots. So thank you for that.
All right, thank you. I'll make one more request if there's anyone attending remotely that has any questions or comments for Dana or Dr. Lawson. All right, not seeing any, we will move on to our business operations component of the meeting, starting with Anya with our financial review.
Good afternoon, everybody. One second here. I'm going to pull it up so I can see it on my own screen because I can't read it that far away. Can you hear me okay? Oh, let me stay close. Okay, got it. Okay, so first we're going to look at the February financials. So Sheila, if you could move to that first page. So this chart looks very similar to how it has been the last couple of months for February. Our revenue is well over what it was last fiscal year, and that's really just primarily due to the eligibility trend that we continue to talk about. You can see that there are two spikes in November and February are related to the direct care wage $2 pass-through, so they tend to do it in lump sums, so that's why there's a couple of spikes there. Moving on to the next slide is the actual eligibility trend that just shows the continual increase in the eligibility trend for basically all populations. Go ahead and move on, Sheila. Okay, so this one I do have to look at my screen. So this first set of columns here is looking at cash and investments from the end of last fiscal year compared to the end of February. So that blue column shows you that cash and investments are up significantly since that point. Again, that's related to the revenue we've been receiving. Receivables is down a bit. Other assets is basically flat, and then capital assets goes down every month with depreciation. Moving on. So this is liabilities, and liabilities, again, is looking at liabilities comparing the end of the fiscal year of fiscal year 20 to February 28th. So you can see our vendor payables has gone down significantly, which is primarily just due to the accruals that happened at year end that have now been paid out. Due to state is roughly half, and that's really just fluctuates for things we pay quarterly versus monthly. Employee payables is relatively flat within a few $100,000, and long-term I can't actually see the word, long-term debt is down slightly, and that's really just going to be the lease we have on the Resource and Crisis Center and the group homes that we own. So those go down every month we pay on them. Moving to the next slide. So net income, so this one compares year over year. So this is looking at the red column being February 28th of 2020 versus 2021. So you can see total revenue is up significantly. Total expenses are down, but you can see them starting to catch up. I know we've seen over the last couple of months expenses being quite a bit lower than the prior year, but a lot of that is just doing to catch up related to COVID and things like that. So we're going to start to see that catch up here in the next couple of months. And then, so that last set of columns there is net income. And so if you look at last fiscal year, if you remember early in the year, we had major problems with the rates that the department pushed out. And so that's why you're seeing at that point in time, it appeared that we had a deficit of about $8 million. That was corrected later in the year with the adjustment to the rates. So comparatively, between the two time periods, it looks much more significant than it ended up being, but we are still in good shape related to this fiscal year. Next slide, please. So revenue comparison is, again, that year-over-year comparison, so you can see that revenue is up quite a bit in this fiscal year. General fund is just slightly less, which has really to do with grant we had from the state for PPE last fiscal year. County funds are flat comparatively, and all other revenue is basically flat, just with minimal amounts. That's going to be grants and things like that. Next slide, please. Expenses. So expenses are a comparison year over year. So administration down quite a bit, but that's still that adjustment in administration that we had last year. Provider network is still down a little bit, but you can see, as I mentioned before, the gap is closing. I believe last month it was, I don't know, 7 or 8 million. So we're starting to catch up now, where you can see that's roughly 3 million-ish, that the difference in expenses. Grant expenses is just slightly down, and then all other is roughly flat. Next slide, please. So net position comparison, again, this one is actually end of fiscal year 20 compared to now. So you can see our net position in total assets has gone up 6 million-ish. Total liabilities has gone down, and so therefore net position has gone up to roughly 84 million. Next two slides are just providers and descriptions, so we can hop past those. And with that, I'll take any questions.
So if there are any questions for those attending remotely, if you can put your hand up so we can make sure we acknowledge you.
I know it's very exciting stuff, so.
I'm not seeing any.
Okay.
Look at that. All right. So we will move on then to budget amendment number 2.
Okay, so lucky me, I get to do that one too. Budget Amendment 2, as promised, makes some adjustments from Budget Amendment 1. I think Budget Amendment 1 we did in January, off the top of my head. So if you click to the next slide, and hopefully some of you can read that, it's fairly small on the screen. But what we're doing primarily in Budget Amendment 2, the biggest change is revenue. So the first budget amendment, we made an update just for the decision to cover I believe it would have been the second quarter of the fiscal year related to the direct care wage increase, because they had not extended it at that point. So Budget Amendment 2 officially adds the revenue for the full fiscal year, because the state has extended that and increased it to $2.25. So that's roughly $15.8 million. We will potentially get in more cash than that, but because of the restrictions they've placed on that, we will likely have to send some of it back. So that's something we have informed the department about, that happened in last fiscal year. They only allow us to use it on very specific codes, and they don't allow us to use it for non-face-to-face time or for overtime. So unfortunately, even though they push through more, we can only use it on the things they allow. So that's the primary change in Medicaid revenue. The other change is in the grant line, and the primary adjustment there is the grant we got from Oakland County that allowed us to purchase, off the top of my head, I'm trying to remember if it was 1,000 tablets. Is that what it was, Nicole? Nicole and I spent some time activating those. So we are very familiar with how to activate a tablet, but they provided us CARES Act money to be able to purchase those. So there were a couple of other adjustments in a few other grants, including children's crisis stabilization, infant and early childhood, mental health consultation, Veterans Navigator, some transportation, and as I mentioned, the primary one being the Oakland County CARES Act money. Moving down to expenses.
Anya, before you roll into there, I have a question.
Okay.
You mentioned the state providing the additional hourly increase, but you said that it didn't cover any telehealth related or non-in-person services. Is that correct?
So, no. So what it does is only covers face-to-face time. So what that means is only time someone is directly in front of an individual. It doesn't cover indirect time. So travel time, paperwork time, those types of things. So they only allowed us to do it for face-to-face time.
Okay, so if they're doing telehealth face-to-face, that's covered. But administrative costs are not.
I'm trying to remember that piece specifically.
If I can answer that. Part of what you're looking at is the $2 increases for direct service professionals. The other services that are through telehealth are actually services through our core providers or our outpatient providers. So those would be considered something different, and those services were covered and reimbursed through Medicaid.
So, to your question specifically, Jonathan, let's say a vocational provider did a telehealth. There were very minimal amounts of vocational providers that were doing telehealth, but that did happen. I don't believe it was applicable, and don't quote me on this because I would have to go back because it went back and forth quite a bit. I don't believe it was applicable other than if you were physically face-to-face with an individual. And the whole point of these funds was, I don't want to say hazard pay because that gives it a negative connotation.
But that's accurate.
Say that again?
That's accurate, though.
Yeah, I mean, it's really intended to because of the increased risk in providing service during a pandemic. So it's really intended for when you are physically face-to-face with someone, so that's why they also didn't do it for the non-face-to-face time. So it primarily hit direct care professionals that were working face-to-face. So CLS, respite, any vocational services that did go on, although there weren't many, they did finally go ahead and add supported employment, which was good because they had excluded that until now, even though they worked pretty much the entire time because many of the jobs were considered essential jobs. So they did add a couple of codes. So there were a lot of restrictions and a lot of rules we had to follow as it relates to just distribution of this money. So that's why we did, in fact, end up sending some back in fiscal year 20, and we likely will in fiscal year 21. And we are not alone in that. I think most, if not all, of the PIHPs had the same situation.
Because it wasn't related to direct services and supports. Okay. Hopefully the legislature won't beat us up for turning money back in or funds that went unused.
So the department did ask us why that happened and how they might help mitigate that, and we did give feedback. Certainly, including supported employment would be one of those ways. But you know, unfortunately, sometimes what the legislature's intent and what comes out may not be as accurate as it might be intended to be. So we all provided feedback, and I think that helped us get supported employment included. But again, the actuarial estimates on how much money we need and how much we're able to push out are two different things.
Thank you.
If I could follow up just real quick, that was basically the same question that I had that Jonathan asked.
Okay.
So thank you for that information. Do we know how much we had to give back to the state? What that percentage-wise, would you have a ballpark or anything to that effect?
So in fiscal year 20, we gave back, I think it was somewhere between 3 and 4 million.
Okay, 3 and 4 million.
I suspect it'll be roughly the same this year. We only book what we expect to be able to utilize, so the revenue we expect to utilize and the expense we expect to be able to push out, because otherwise if we book it as revenue and not as expense, it's going to make our bottom line look higher than it actually is. So we don't book it that way, because we know we have to give it back.
And then we were able to give feedback, you said, to the effect of why it was, so that the legislature could re-examine reasons or restrictions that they put forth on any further money.
Correct. Ideally, we would have been able to include overtime, because it seems not to make a ton of sense that you wouldn't include overtime in the allowability, but that did not change, unfortunately.
Thank you.
If there are no other questions on revenue, we can move to
Not
expenses.
a question.
Oh,
Nicole, I'm sorry.
You're looking at Nicole. It's okay.
I'm looking at Nicole. And I hate to say this, but this configuration is difficult because you can't see the other end of the room. I don't know what we can do different the next time. If we could do it more circular, it might be helpful. But I don't know what we can do to encourage, especially at the state level, that they include us in the planning. Instead of rolling out this stuff. They haven't done the work, they don't know what we do, and then they make these determinations, and it makes us look bad, when if we would have had input early on, some of this money could have stayed in the system. And that's what really irritates me, because it makes it look like we don't know what we're doing, but it's not us, it's them. They need our input. They don't do the work, so they don't know what's involved. And I don't know what it's going to take to get that message across to the department and to the legislators, so they don't understand, and they come riding into Lansing on a high horse. They're going to fix it, but how can you fix what you don't know what you're looking at? You can't fix it until you know what you're dealing with.
Yeah, I mean, I would agree, and I think that there was a lot of advocacy done as it relates to the supported employment, and I think that's how it got back in there. So it does work. I think there are additional tweaks that certainly, if it were up to me, I would change. And that's, again, why we participated in them asking why we had to give money back and what were some of the challenges in distributing the money. Because, everybody thinks if you get more money, it's real easy to distribute. It's really not. Especially, I mean, if you think about Medicaid in general, and then all the extra stipulations of the legislature having a say on what code you use, when you use it, whether it's face-to-face time or not face-to-face time. Because the reality is it's still one person getting paid. So to say it's allowable for face-to-face and not the drive time it took them to get to provide, you know what I mean? Like, it's a lot harder than it sounds. And it's a lot of administrative work to be able to document and make sure we can support the expense that did go out the door. So, I mean, anybody's ear you can get, have at it.
Just one follow-up, too. When it deals with administration, that's one of the things they want us to keep low.
Yes.
But they keep doing things that push the administration costs up.
Yeah, and I could spend hours telling you about all of the state reporting that's been added over the last couple of years.
It's ridiculous.
And that's it. And so just this stuff alone takes a lot of work for us because we have to report it all separately, and by specific months at a time. And it's far more work than I think it's intended to be, and also than people realize maybe. Eric.
The point that Melchiah brought up, in my mind, gives us an opportunity. There are some board members that look forward to advocating for better public policy in Lansing. And while we will pray and hope that things get better in future months, we don't know what the future looks like. And unless we are letting Lansing know what kind of rules that they should be adopting on a continuous basis, that's a missed opportunity for us. So I don't think that we should just assume that, this is the last increase and the last time that we may face this. And so I think that we should try to be proactive and maybe in the coming months, there's an opportunity for the OCHN staff to kind of guide us board members on how we could help explain what they do in Lansing could be done better.
Okay, am I okay to move on here? I don't know if anybody online, oh, I thought I saw a hand.
Dr. Hans, is your hand up?
Yes. Anya, help me understand the overtime is not covered under that $2.25 increase. So the ECWs who are putting in overtime, how are they compensated for that?
So they would be compensated at their normal overtime rate. So essentially, it turns out to almost be a penalty or not worth really doing overtime. I mean, it just depends on the person's rate. But unfortunately, we were not allowed to use it on overtime hours. So that individual, if let's say they were making $10 an hour, made $15 an hour in overtime, we would not be able to bump it up to the 17, whereas if they were in regular hours, we would have been able to pay them the 12. Doesn't make a lot of sense, but unfortunately.
It doesn't make a lot of sense when you are caring for people. Most of the time, or many times, not so most of the time, because I don't know the overall picture. But what I have seen on the ground is that overtime sometimes means incurred because the person who was supposed to cover the next shift did not arrive on time, or they were running behind, or they had a flat tire, or any number of reasons, and the person ends up staying couple, 3, 4, 5 hours sometimes over their shift. So yeah, I think that is something that we need to advocate for, because this is really hard work, and I mean, not many people can do it day after day after day. So that's something also that we should be looking at or talking about more.
Yeah, I agree with you completely. I also, when we had to give money back, it's incredibly frustrating to disincentivize people from staying and helping people in the middle of a pandemic and a staffing crisis. So it's, it's very hard to, we have to follow the rules, unfortunately, and we just make sure we provide feedback on the ones we're struggling with a bit and hope that they do better the next time, or even at least ask what our thoughts are on how they roll this out.
Mr. Landsman, is your hand up? I can't read whose hand that is.
Oh, I might be able to see it on my screen.
It was because I was trying to get your attention for Dr. Hans, for Bajaya.
Oh,
That's it.
thank you. Yeah, it's hard to see from back here. Okay,
All right,
moving on. Anya.
so
Thank
are
you.
we okay now then? I don't want to cut anybody off, but I think we're okay to move on to expenses. So I'm going to have you go one back, Sheila. Okay, so expenses, the adjustments in budget amendment number 2 for expenses include an expense adjustment for administration that includes the learning management system that we are implementing, a couple of staff positions to better align with Mdhhs priorities, the community education that we have talked about related to a couple of TV stations, the compensation analysis that we talked to you about I think it was last month, and our website redesign. So all of those cumulative adjustments are about $600,000. And then moving down to provider expenses, primarily what you're seeing there, that first one you're seeing is state facilities, and that's just an increase to the expense of state facilities, and what that means is we're just utilizing them a little more than we had in what we budgeted. So increasing that to be roughly what we expect to spend. We have a bit of an increase there in the grant expense, but that coincides with the increase in grant revenue that we already talked about. We have an increase to the Resource and Crisis Center expense That's just related to maintenance and repairs and things like that. And then the rest of the increase is related to that direct care wage. So what we do is we put the revenue to equal the expense so that it flows through both sides of the balance sheet there. So the total adjustment to our change in net assets is an increase of about 1.4 million. And that's really primarily due to the fact that, remember, we budgeted to cover that 1/4 of paying that direct care wage increase, whether the state continued it or not. And now because we get the revenue for it. And so therefore it frees up some revenue that was already budgeted to be expensed. So with that, let me jump to the next slide. Sorry, I forgot about the next one.
Before you,
Go ahead.
I have a question on LMS, your learning management system, or a couple of questions. Do we know what the cost is for that item, and is that a subscription, or are we buying a license to it?
I am going to look at Nicole for her help on that one.
Yeah, so, I'm looking right now. It looks like we're buying a 2-year, I'm not sure if it's a subscription or not, so we can check in on that and get back with you, but in terms of cost, the first year cost is, about $33,000 plus a $6,000 implementation fee, and second year cost was about $39,000, so 2 years for about $78,000.
Okay, so under our CLIP level for approval.
Yes, and
Okay.
significantly less expensive than what we had originally anticipated, so we were very happy about that.
And they usually are much more expensive. That's why I was asking.
Yep.
And I don't know if Diana had anything to add.
It is subscription.
Thank you.
Okay, so assuming no other questions, we can go on to the fund source summary page. So this is the document you guys are familiar with. It just looks at things from a fund source perspective and kind of really groups together the fund sources that are a little more interchangeable. So Medicaid, where this puts us with all of our Medicaid fund sources that can be commingled, is roughly about $7.8 million to the good, so that's always good news. If you go down to the center section there, general fund, local, and all of that, we end up with about $2.9 million. And then finally down to the substance use section is about $2.2 million for a total surplus of about $13 million. So remember, I say this every time because I don't want people to think there's money to burn, is that the reason we got through fiscal year 18 and 19 is because we used our reserves. And we did not make any provider cuts, no cuts to any services and things like that. So now, as the finance person, I'm going to tell you now is the time we need to put some back away, because should that and when that happens again, we will need to be able to use our reserves again to make sure that we can sustain the services within the network. So this, barring any questions, will be an approval item at the board meeting. But with that, I can take any questions.
Is there anyone attending remotely that has questions or comments for Anya?
I have a comment about Eric's last statement about educating us. Not so much about that, but since we're doing more with the media, I'd like to suggest that we look at doing something around a day in the life of a direct care professional, and put it on TV so people can see what it's like to do the work that they do. Because a lot of the decisions that are made in Lansing they're based on stigma. They don't understand that a lot of people, this direct care increase kept people from having to work 3 jobs. And I hear people saying people don't want to work. It's not that people don't want to work. They don't want to work 3 jobs. They want to be able to spend time with their family. They want to have health care. If we could somehow help to illustrate to the public what it is we're advocating for in a way that they could understand, I think it would make a difference. So I just wanted to suggest that.
Sarah stepped away for a minute, so I don't know if,
This is Jonathan. So with her stepping away for a minute, I just wanted to say one thing. We are going to have a vote on the budget at our next board meeting on this budget amendment. So this is a good place to have questions, if the board has any. All right, and I think, Malkia, your last comment is probably a great comment to have said during our board comments at the end of the meeting. But I do agree with you. We have to find a better way to communicate to the legislature about what our people that provide direct services do and the challenges they face. If there's no other questions on this topic, why don't we move on to the next item on the agenda? Diana?
Thank you. Good evening, everyone. Next week, I will be bringing forward to you for a request for approval to, for our Dell Enterprise Agreement. Prior to 2018, OCHN had procured Dell products individually, and instead what we did was we consolidated those into what is called an enterprise agreement. Every single enterprise agreement is for 3 years. Ours is expiring this June, and it covers our licenses for databases, servers, Windows, our subscriptions for Office 365, telephony, and Power BI, and some other functionality as well. In February, we issued a request for quote to get the best enterprise agreement pricing. We received 5 responses, and Dell was selected as the vendor, and they provided the best pricing. It is important to note that they did use a cooperative agreement for the pricing that we received, which is a 3-year total of $577,000 and some change, or approximately $192,000 annually. This new agreement will expire in June of 2024. I did add a contingency of $30,000 a year, or about 5% to the total contract, because as soon as we add a new employee, add new equipment, we will be over that not to exceed amount. So it just gives us flexibility to have that $10,000 a year. One important note is that in June, the board approved the 3rd year of our last enterprise agreement, and that was $212,000. So we have actually saved a little bit of money on this, and by moving to Microsoft in general, we continue to save about $100,000 a year when we move to Power BI and to their telephony. Are there any questions?
Board members? Diana, I have a question for you. I know this was a bid that went out, and I think we used in the past CDW.
That is correct.
All right. Did we get any favorable pricing like what the county gets? Or what group rate did they put us into to get this reduction in our cost?
Yep.
Do you know?
So just an important note that you are right that CDW was our previous vendor, and Dell provided lower pricing for them. And Dell is using, and we actually use this contract cooperative purchasing agreement quite a bit, it's the Midwestern Higher Education Compact. So typically what these vendors do is they will quote based on those that they can quote off of and then give us the best pricing. So whether it's MyDeal or MHEC.
Do we know how that stands against the county's rate?
I do not know that because that is what they quoted.
Okay.
My guess is this would be better than the counties because it's looking at many more organizations than just Oakland County.
Okay. I wonder how we qualified for a Midwest educational discount.
We do qualify through that, and if you want to take that one?
Sure. As a governmental entity, we are allowed to basically tag on to other agreements that are negotiated and or awarded when they fall within that cooperative standpoint from the governmental agency perspective. So that's how we were able to actually tag on and utilize their actual negotiated rates that they provided to that organization.
All right. And you were involved with this, I assume, negotiation.
I am aware of the rates that were provided. The negotiations were limited to the extent that they were rates that were already developed and given to the other orgs or other governmental entities. So we are in line with those negotiated rates. And those rates are actually the best rates that we received based on the proposals returned from 5 vendors in total, I believe.
Do we think the $10,000 contingency is going to be enough for year over year? Dana?
I'm hoping that will be enough. I mean, that is usually what I like to do, a contingency of between 5 to 10%. If we find that it's not enough, we would just bring that back and ask to have the NTE increased.
Okay. Thank you. Other board member comments? All right,
I'm
thank
back,
you.
Jonathan. There's no more.
Thanks,
so,
sir.
yeah, thank you. Sorry about that. All right. The next, just a statement. I think this is newly added, but Mr. Cohen, we have you on here as committee assignment, and so with our committee of the whole, there is a business ops committee and a policy committee, and those assignments are typically done in October. And at this point in time, there is a vacancy on the business operations committee, so we would have you assigned to business ops, and then in October, if you wanted to switch to the policy, you would have the opportunity to make that request in October.
I'd be glad to fill that vacancy if everyone will have me. Thank you.
Yes, thank you. Okay, and so now we are going to move on to the policy management component of the meeting, and we're going to start with quarterly updates. So our provider network team with Jillian.
Good evening. Can everybody hear me okay?
Perfect. Yep, thanks.
Okay, great. Hi, I'm Jillian Trumbull. I know I've met some of you in person, some of you virtually. I'm the director of the provider network team at OCHN, and I'm going to give an overview of a few of the things that we've been working on over this past quarter. This is an org chart highlighting the team and their roles. I'm not going to go through that for you. You can take a look at it at your leisure. Next slide, please. And then here's just a brief department overview. There's 14 staff on my team. We oversee, with the exception of the substance use network, we oversee the provider network, which includes our core provider agencies, our specialized residential providers, ABA, vocational, crisis and hospital services, many other ancillary types of agreements, and then we manage many other strategic priorities of the organization, waivers, et cetera, and you'll hear me talk about some of that tonight. Next slide, please. So for tonight's update, I'm going to give brief overviews of our fiscal year 22 contract, some standard operating procedures related to various waivers that OCHN oversees, and then self-determination. And I will offer an opportunity for questions after each specific section. So for fiscal year 22, one of the things that we are working on right now is the contracts. Contracts start on 10/1 at the end of our fiscal year, and it's necessary that we have contracts in place for continued operations. Most of OCHN's organizational contracts require renewal after 1 year. Hospital contracts are 3 years, but most of the others are 1 year. So we utilize standardized contract language. So core provider agencies have the same contract. Vocational providers, there's a vocational provider boilerplate, specialized residential, et cetera. So we don't have various versions of the same type of agreement floating around there. Right now, we're going through the process, and this involves many other people, heavily involves our contracts and procurement team, of reviewing all of the contract language, making any changes that might be required for fiscal year 22, with the goal of having documents in providers' hands, final draft documents in provider hands in October, to give them some time to review, ask any questions, and have contracts finalized, signed, in place by 10/1. And along with that, this is an overview of the various contracts where we are working on new agreements for fiscal year 22. I've listed the type of provider and then the number of providers that fall into that category currently. Are there any questions on that item?
I have one, Jillian.
Sure.
On the contracts themselves, with the increased need that COVID has provided, has there any thought been given, especially in the area of children with serious emotional disturbance, to open up the contracts to bid for more providers?
So we do have those conversations, Melkaya. You know, we have to follow federal procurement guidelines. So we are looking at the network as a whole and where it may make sense to open the network and look to bring in additional provider types. I will say that specific to specialized residential and community living supports providers, we have been able to add some on an emergency procurement basis because of the COVID-19 pandemic, but adding new core providers or new ABA providers, for example, would need to go through a more formal bid process, but that is on our radar and something we're discussing. Does that answer your question? Okay.
Yes, thank you.
Yes. Are there any other questions before I move on?
You know what, this is Hadass. I just want to follow up with Makaya's question. It was such a good question. When you say it's on your radar, what does that actually mean? Like, does that mean within the next 6 months, this year, the next 3 years, 5 years? You know, what does that actually mean?
Sure. So we're talking about it as part of our annual and strategic planning. So the goal is that we would have a bid schedule developed that will define the next 3 to 5 years. Does that answer your question?
Basically, that it'll be in the strategic plan. Is that what you're saying? And then that will determine whether this will be open up for new providers. Is that what you're saying?
What we do is we discuss the RFP process when we open up to bid, and so we're developing a schedule. So we would look at when are we going to open up to bid for ABA providers, for example. When are we going to open up core provider agencies to bid? And so those discussions are happening as part of our annual and strategic planning, so that we can prioritize and then develop a bid schedule for the next several years.
Okay. Yeah, that answers the question. Thank you.
Yep. Okay.
I'm sorry, Jillian, before you go on,
Sure.
going back to that question about opening up, how do you determine how many providers you need in any one category? What's the, go ahead.
It depends, and I hesitate to kind of give a hard and fast answer because there are some pretty strong federal procurement rules, and I'm not the expert in that area. But what we typically would do is say, you know, right now we have, and I'm gonna make up numbers. We have X number of children's providers. So we know we need a minimum of that, and then we would look at the population in general that's served. We would look at locations, and we would maybe do a range. Like, we're going to select X number to Z number of providers that submit qualifying bids.
Okay, so the follow-up question, I guess was my initial question, with the increase in need that this pandemic has brought to bear, would that bring any sense of urgency, or is it just business as usual?
So one other thing I want to mention is there are also Mdhhs provider capacity guidelines that we follow and are compliant with that look at how many provider types and services you need to have in place for certain types of services. So as I mentioned before, we have been able to open the network under emergency procurement for for specialized residential and CLS services, which are the primary services where we have seen challenges in meeting people's needs. So that network right now, we will add providers as they come in, and we're able to do that under emergency procurement. But we can't just open the entire network under emergency procurement when, like, for example, supports coordination is still continuing and we haven't seen supports coordinators leaving en masse or the service not being provided, et cetera. Does that help answer the question?
If I may actually tag on to that, Jillian.
Sure.
Now, Kaya, this is Kalana. So a part of that is also assessing our network overall, right, what the need is. And it's similar to what Jillian said, we're going to look at the services, the need within our network. Are we filling the need for services in certain areas? And so that will also serve as a basis for us to open up the network as well. And we will look at that on an emergency basis. So to your point, given the stress that COVID has caused on our network, to what Jillian said, we did open up the network for on an emergency basis to add providers where we have identified a shortage or a lack of providers, whether it was due to COVID or a lack of staffing and things of that nature. So as we move forward, though, we'll continue to assess the network overall based on the current trends and what we're seeing in services and make that determination. With that determination being made, there will be a set criteria of what those providers will need to meet in terms of quality, staffing, all of these things that will be qualifiers from financials and anything else that you would need to assess a business before you enter into an agreement with them. And so that's how we would essentially determine that. Does that kind of answer your question?
It kind of answers my question, but I still have a major concern because I'm in the community, and I've heard especially teachers and school administrators talking about the number of suicides that are taking place. I guess I'm just concerned that we hold to business as usual when we're not in a business as usual situation.
If I may, the other thing is that as I came on board and started looking at the need of the community, and of course COVID has brought about a whole new population of need, and listening to where the state's direction is going with some lawsuits that have occurred and things of that nature, and just even seeing the increase in cases that are high level or high profile because of the lack of service availability and our inability, maybe not our inability, but statewide inability to really work with the hospitals and those contracts. We have no leverage with the hospitals, so we have to identify other ways to support children. So with that being said, I understand from the state that it is one of the priorities to have an integrated healthcare system for children. So in looking at that and how it impacts OCHN, we'll look at our need and our capacity and really determine when it's appropriate to open up the network. And we may have to do it on an emergency basis, or there's some other ways to say, we have providers already providing services. Do we want to empanel them to also serve children? And so they would have to meet certain criteria and things of that nature. But we are looking at that, and we want to align with the state because we know that there are some things that are coming down that they will probably require of us.
Thank you, Dana. Thank you,
You're welcome.
Ali. And thank you, Julian.
Sure. Are there any other questions on that item? Okay, so moving on, the next item I wanted to update the board on is some standard operating procedures related to the 3 waivers that we oversee, the Children's Waiver Program, the Habilitation Supports Waiver Program, and the Serious Emotional Disturbance Waiver. I did not add a detailed slide with numbers or eligibility for those waivers. It is included in your quarterly board packet that you received, but if there's any questions related to that, I am happy to answer. One of the things that has happened over the last year is there's been some changes in the administrative operations of that waiver. Some of the things that were historically overseen and completed by the Michigan Department of Health and Human Services have been delegated to the PIHPs and CMHSPs. And there's been some changes in the waiver support application, which is the Mdhhs system for monitoring and tracking waiver eligibility, enrollment, et cetera. So it's been a big lift this year to really just look at, revise, and implement our policy, procedure, and protocol related to those waivers. So that, it's important to people served because we want to make sure that everybody who can be eligible for a waiver has access to the waiver, and we want to make sure that no services or eligibility lapses because of operational inefficiencies. Are there any questions related to either the standard operating procedures or those waivers? I'm not seeing any. I can't see the room, obviously, so please let me know if I'm missing anything. And then the
All
last,
good. Jillian, let
Okay.
me just add for the new
Sure.
board members, I know we use a lot of acronyms and abbreviations. So if you want to understand some of the specifics of the program, they are on the narrative piece of the report. And they talk about the specifics of each of those waivers and the
Yes.
population of children that they serve.
Thank you,
Or
Dana.
adults.
Yes.
You're welcome.
Thank you. And I would be happy to answer questions at any time for any board member related to those waivers should they come up. Okay, so the next item I wanted to talk about was self-determination. This is an item that is an ongoing priority of OCHN and the provider network team. It falls under the annual plan goal of community education. And it's important for us as an organization to create opportunities for outreach, training, and support regarding self-determination to all populations. The impact is we want to make sure that both providers and people receiving services have information necessary to make educated decisions about self-determination and if or how it may work for them. Each core provider agency does have somebody who's identified as a lead in self-determination. We have a lead, a subject matter expert, Rachel Densmore, that sits within our own organization related to self-determination. And I know she's on the call listening in, and she's going to virtually kick me if I misstate or misspeak related to anything. But we do host quarterly meetings to provide any technical assistance. She sits on many statewide committees related to self-determination, and then we are always looking at training opportunities for our provider network and for people who receive services. So next slide, please. So one of the things I wanted to talk about was sort of the tenets of self-determination and then the philosophy of self-determination, whether as opposed to self-determination as a program. So these are the tenets of self-determination. They come from the Center for Self-Determination. While I typically don't read slides, I do kind of want to go through this specific one. So the core tenets are freedom, that everybody should have the opportunity to decide how they want to live their life, authority over a targeted amount of dollars or your budget, support to organize resources in a way that is life enhancing and meaningful to you as a person. We all know if we talked about our days, we would all have different priorities and different schedules, just like people with disabilities. Responsibility for the wise use of public dollars and recognition of the contribution individuals with disabilities can make to their communities. And then confirmation, which is, nothing about me without me. So that's, self-determination is rooted in that philosophy. OCHN and our core providers, we hold true to that philosophy. We believe in that philosophy, regardless of whether as an individual served, you choose to engage in a self-determination arrangement. We would expect that people receiving services have the option to choose their case manager or supports coordinator or therapist or other type of service provider. And if that service provider isn't working out, not meeting the need, to say, I need to identify a new case manager and supports coordinator and have the support and resources to be able to do that. We expect every core provider and people who receive services to have access to what the cost of those services may be. We strongly value nothing about me without me. So the philosophy of self-determination, regardless of who you are, regardless of your disability designation, that's something that we hold true, we value, and we really want to promote to all people receiving services. It gets confusing, and that self-determination also is a program. So there's numbers that we report related to who's enrolled in self-determination, and you can switch to the next slide. There's numbers that we report related to who's enrolled in self-determination, and you'll see those numbers in front of you. For the two IDD providers, intellectual and developmental disabilities, I will try not to use acronyms. that's where the majority of self-determination arrangements exist. When you look at the providers for adults with mental illness, you see much lower numbers. That's very true across the state. Oakland County is, I think, still the leader in self-determination across the state. And you would see a similar breakdown if you looked across the state. One of the things that we've heard, and I know Dr. Lawson talked about when she was presenting last month, the days are kind of blending right now, is that we have heard from people with mental illness that they don't know that self-determination is something that they would benefit from. And so we've really kind of wanted to take a step back, really look at it, hear from people who receive services, and assess, is it that people with mental illness and maybe core provider agencies are having trouble understanding self-determination, which becomes pretty complicated and is especially complicated with certain service types, or is it that they're really not interested in the program of self-determination? Most self-determination arrangements are established for services that are provided in one's home, such as community living supports or respite services. Those are services that are most frequently authorized and provided to people with intellectual and developmental disabilities. It requires a contract or a self-determination agreement between all of the parties, with the fiscal intermediary paying the professionals under the self-determination agreement based on the review and authorization of the person receiving services. So for adults with mental illness, those services, not that they're never authorized, but they're authorized with less frequency. And the services received are typically more related to therapy, psychiatric services, etc. And that seems to kind of be where there maybe hasn't been as much interest or as much interest in utilizing community therapists or community psychiatry for self-determination arrangements. I do see that Jonathan, I think, has his hand up.
I do, thank you.
Yes.
I have a question for you with regard to the self-determination aspects. How are we approaching working with the courts to help them understand there are more options than just guardianships?
So that's sort of a separate conversation from self-determination. Vicky Suter does lead a work group that I believe supported decision making is the title of the work group, and that group is focused on working with courts, with the community, with people served to understand alternatives to guardianship. But I'm not sure I can answer the specifics of your question tonight, Jonathan.
That's fine. I just wondered if there was some coordination with that, because that seems to be one of our challenges, is really having, because they are a separate entity from us, clearly, but helping them understand the options so that not only are we educating our folks on self-determination, but they also know on the other side of the coin that there are those options.
Yes, and I do know that there are specific goals related to that, and Vicky Suter and that work group is working very hard.
All right, thank you.
Sure.
Go ahead, Sarah. Good. Because I see Bajaya's hand up.
Is it my turn, Jonathan?
Well, Sarah gets to decide that, but I guess so, yes.
So yeah, it's a little bit concerning to me that self-determination is not as available, or there is no acceptance of it by court providers. I would like to understand what are the barriers, because from my point of view, that the therapies or any treatment or any kind of support is more effective when the person who is receiving the service has some autonomy over who is providing those services. So I think that really impacts the outcomes of
Sure.
whatever try to do. And at some point, maybe we could have a little deeper dive into that as to what are the barriers? Why is it not available to more people?
Sure. And I think I can kind of answer your question, but probably not with the depth that you're looking for at this point. So I wouldn't say that the adult core providers are resistant to self-determination agreements. I would say that there's a lot of confusion and a lot of, and including within MDHHS, or the Michigan Department of Health and Human Services, including within Oakland Community Health Network, including among people receiving services, about how to sort of wrap self-determination agreements and put them in place in ways that are supportive and meaningful to adults with mental illness. So the other thing I would say is that in situations where people are self-directing, when you're looking at community therapists or community psychiatrists, and I'm selecting those two because I know those are the primary services authorized and received in the community of adults with mental illness. They're not necessarily interested in establishing a self-determination agreement. It requires them to have a contract with the individual receiving the service. It requires them to have a contract with the core provider agency. It requires them to accept the Medicaid rates, which they may or may not accept. So there has been some resistance in the private community. And I don't want to say that as like a wholesale statement, but we've seen some resistance in the private community to establish self-determination agreements. And then there has just been, challenges in making sure that from a programmatic standpoint, all of the procedures and protocols and state requirements are being followed associated with that. And in terms of being able to select their treatment team and having input into that, OCHN as an organization, we agree with you wholeheartedly. We would expect that if an individual is receiving services at CNS, for example, they have the option to have choice in who their therapist is that's employed by CNS. If they don't like that therapist, if that therapist isn't a good fit, to change therapists. If they don't like CNS as an organization, to change to one of the other core provider agencies. So we do try to, and we promote and encourage and expect from the core providers choice in that sense. Within the philosophy of self-determination. But those are some of the challenges that, we see and that we hear from the programmatic perspective.
Thank you, but I still hope that at some point there can be a presentation on this self-determination vis-a-vis adults with mental illness or mental health issues. Thank you.
Sure. Are there any other questions? I'll cover my next slide while letting people ponder if they have any additional questions. For all of the items covered tonight, the fund source is Medicaid with some general fund for all of the items, and no additional costs were required for the fiscal year 21 budget. And I have a chat from Nicole that Malkaya is trying to talk and you can't hear us, and that is true. I cannot hear you. Can anybody else hear the people in person?
I can't either.
Okay.
I think we're going to have to move on. Oh.
I know Malkaya, I shouldn't say I know. I imagine Malkaya has some strong feelings on this as well. I know she has in the past. They're checking their mic right now and trying to fix it. I can see the room right now.
All right.
Oh, I can hear. It's very echoey though.
Maybe someone could type her comments in the chat.
It looks like Nicole typed in the chat that they're trying to fix. They think the mic may be muted.
Okay, shall we move on with the meeting?
Can you hear us now?
Yes.
Okay, thank the Lord. Jillian, I just want you to know, I didn't think you would run past me like that. It just was a little disconcerting. I'm talking and you just kept going. But
I'm so
anyway,
sorry.
no, I know it wasn't you. It was technical difficulty. But yes, you're right. I have very strong feelings about this because everything that you outlined for adults with mental illness, choice, being able to choose your case manager, choose your therapist, choose your psychiatrist, you can do all that now without self-determination. So all I'm asking for is for someone to break it down for me in a simplistic way that would show me what the benefit would be. Because personally, when I was receiving services, I wouldn't have wanted a self-determination arrangement. I wouldn't want to have to figure the dollars and handle the budget when I could just do it without doing that. And I'm just one person. So I just need to see a simplified explanation for why putting the dollars in my hand is going to make my service delivery better for me when I have choice without that. Because I had to fire a case manager, and I worked in the agency, and that was very uncomfortable. But I had choice, and I exercised my choice. People are exercising choice every day without self-determination. So it needs to be simplified, and if the state can't explain it, then I don't know how OCHN or anybody else is going to be able to explain it for adults with mental illness in a way that we can accept it and want to run with it. Because it doesn't make sense to me as an individual that went through the system, why it would benefit me.
And so, Melchiah, I think you kind of are getting at the crux of why we sort of wanted to take a step back and really kind of hear from providers, hear from people with mental illness, and really try to understand it in a little more detail. I think even in the IDD world, self-determination is a benefit for some people. For others, they don't want the work associated with it. What we really need to understand for adults with mental illness is, you know, certainly we're going to offer it, and if somebody wants it, they have access to it, right? But is it that people they don't feel that there is a benefit to it, by and large, and they understand it and still don't feel that there's a benefit to it? Or is it that we really don't understand it that well, so people don't know if it's a benefit or not? And I think that's kind of where we're at right now and trying to figure all of that out.
I see Dr. Hans has her hand up.
Yes, I think I just wanted to clarify that self-determination, I think, should be available. Now, it's possible that majority of people, and I'm not an expert on this, and I can't say from even personal experience, but what I've seen is that in my circle of people that I know with mental illness, as well as substance use disorder and other kind of issues, that self-determination does help. That should be an option available to people, whether they choose to do it or not, or avail of it or not, should be up to them. My intention is not to certainly impose it on or make it a rule, but at least we should study it a little bit more as to why it is not implemented.
Yes.
Generally.
And we agree with you, or I think I can speak for the organization. I'll speak for myself. I agree with you, Dr. Hans. And certainly there's no intention of OCHN to eliminate it as an option for anybody receiving services. So I hope that helps answer the questions.
Thank you.
Yes. Were there any other questions? I don't want to miss the people in the room again.
I'm not seeing any hands up here in the room, so
Okay. Well,
thank you very much for the information. It was a great presentation.
thank you.
Yeah. All right, so I will move on to our next item under program compliance, which is the mental health proclamation with Christine.
Good evening, everyone. Thank you for the opportunity to present this proclamation recognizing May as Mental Health Awareness Month. For our new board members, there are a number of national observances that we recognize with proclamations. Others we recognize with press releases or social media campaigns. We do revise this proclamation based on issues or current situations in our community. This proclamation is being presented to you for approval, so it will be an action item at the board meeting. But we also send it to the Board of Commissioners and then to all of the city and township councils across Oakland County for their acknowledgement at their meetings as well, recognizing May as Mental Health Awareness Month. So I will read it for you this evening, and then I think it will be on the consent agenda items. So Mental Health Awareness Month, May 2021. Whereas mental health is important for our individual well-being and vitality, as well as that of our families, communities, and businesses. And whereas the COVID-19 pandemic has been a reminder of the importance of integrating mental health into preparedness and response plans for public health emergencies. And whereas younger adults, racial and ethnic minorities, essential workers, and adult caregivers reported having disproportionately worse mental health outcomes, increased substance use, and elevated suicidal ideation associated with COVID-19. And whereas 1 in 6 U.S. children ages 2 to 8 years old had a diagnosed mental health, behavioral, developmental disorder. And whereas May 6th, 2021 is designated the National Children's Mental Health Awareness Day, and May 2nd through May 8th, 2021 is designated as Children's Mental Health Awareness Week. And whereas Oakland Community Health Network is committed to being a zero suicide organization and cultivate a network of providers who are engaged in the zero suicide philosophy. And whereas mental illness is a biologically based brain disorder that cannot be overcome through willpower and is not related to a defect in a person's character or intelligence. And whereas mental health recovery not only benefits individuals with mental health disorders by focusing on their abilities to live, work, learn, and fully participate and contribute to our society, but also enriches the culture of our community life. And whereas the Oakland Community Health Network, OCHN, and its service provider agencies are committed to inspiring hope, empowering people, and strengthening communities. Now, therefore, be it resolved that Oakland Community Health Network hereby recognizes May 2021 as Mental Health Awareness Month. OCHN calls upon our citizens, government agencies, public and private institutions, businesses, and schools to recommit our state to increasing awareness and understanding of mental illness and the need for appropriate and accessible services for all people with mental illnesses to promote recovery. Are there any questions about the proclamation or how we distribute it? I do have one.
Mr. Torres, you've got a question, sorry.
Oh, hi. This is John Paul. I just have a question. I see it says on here to all Oakland County City and Township Councils. Could we include school boards on there or school districts as well? I know I was formerly on my Waterford School Board, and last year when we passed this, I had brought this before my board. So I think it would be good, especially as we talk about youth and children who are in need of services as well.
Yeah, absolutely, we can do that. I do want to share that we gave this proclamation to all the other CMHs across the state, and they are going to follow our practice in recognizing Mental Health Awareness Month in this manner. But absolutely, we can send it out to the school boards. That's a great suggestion. Thank you.
Thank you.
Jonathan?
I have a different question that's related to these kinds of proclamations and announcements. I know I know that in the past we have sent out announcements supporting diversity and other things like that as well. I know this past week there's been a significant amount of organizations that have done press releases on secure elections and ample access to voting. And I wondered if we had intended to do one of those, especially because we worked so hard to help ensure that the folks that we serve can get to the polls or can vote even if it's virtual.
We have not in the last week or so. I mean, we do some activity when it's an election year. That doesn't mean we shouldn't get involved in that. So I'll check into that. Thank you.
Yep. I think it's more of the access to the voting.
Yeah,
messaging.
I appreciate that.
Okay, thank you. That was it on mine.
All right. Any other questions or comments for Christine? I am not seeing any, so we will take this up for a vote at the general board meeting in April. We are in April next week. All right, thank you.
All right.
All right, so we're going to move on to our legal update with Kalana.
Good evening, everyone. Kalana Ali here, Chief Legal Officer for OCHN. You all received, I believe, last week a email with just an update of an OMA overview for meetings that we will now be holding utilizing a hybrid model, which means that some will be in person and some members of the board will be remote due to one of the qualifying reasons, and that includes a health condition, military leave, or the declaration of a public emergency or state of disaster as determined by that governing local body. To that end, were there any questions regarding the information that was distributed as it relates to what the requirements are? We've already asked that the board members who are attending in person update Sheila in advance of the meeting regarding their attendance, whether it be remote or in person, as well as complete a survey regarding screening to determine whether or not there is any exposure there as it relates to COVID-19. That's pretty much it. It just kind of outlines what the qualifying reasons are for each board member attending remotely, and this has also been distributed to the RAC committee as well as the SUD Oversight Policy Board as well for their assistance in conducting their meetings as well.
I do have a question for you. I'm just wondering, knowing that the numbers seem to be going up in the county, is there any talk that Oakland County is thinking of ordering I think it has to come to the county, right, for a state of emergency or anything like that. So have you heard any?
I have not. I have not seen anything from the city of Troy either. I do check their website regularly, and in fact, I believe Troy is actually hosting their city council meeting tonight at 7:30 or something, I believe. So unfortunately, I have not. I did see that MDHHS is intending to extend their work from home order from OCHN. However, that has not yet been released, so I will wait for that, and that is expected to be published later this week. That does not impact our meetings that are required to be held pursuant to the OMA, though.
Thank you. Any questions or comments, Mr. Lindemeyer?
Thank you for the update. Can you talk a little bit about what the definition of a health reason is?
Sure. So as the document that was in the document that was distributed, I footnoted what a medical condition is, and it's an illness, injury, disability, or other health-related condition. So anything that falls within that category of things.
Thank you.
Did that answer your question?
Yes, I just wanted to make sure that the general public understands what the definition of a health reason is, so that people understand why some of the board members may not be here.
Right.
In person.
Correct.
Mr. Torres?
Yep, just more information, or question. When I was reading the information, it indicated that, the meetings are open to the public, and the public is actually allowed to attend, but we can make, like we are doing now, it available virtually to them as well. But should we get more than I guess that would violate the guidelines as far as space goes, then rather than shutting down the meeting, we'd have to go to a larger venue. Is that correct?
So yes, so right now we currently have, I believe, 2 overflow rooms. The purpose of having a hybrid board meeting is to encourage members of the public to actually attend virtually. That would mitigate any risk to members of the public as well as members of the public body here today. To the extent that we do not have the sufficient capacity to house members of the public within this room and the overflow rooms that have been designated, we would then need to shut down the meeting to the extent that we have to turn someone away.
Okay.
What is
I
the
don't
current,
foresee
is
that
it
for him.
25? I'm sorry, 25?
No, so,
No.
I'm sorry. No, the current limitation has been actually expanded, so the Mdhhs order was amended to eliminate from the limitation of 25 persons from that order, from the current order. So right now, I believe it was 50, which was in the FAQ. However, as long as we can accommodate the social distancing requirements, we can actually have people here. And so I believe the current number is about 36, if I'm not, give or take.
Okay, thank you. I see Dr. Taub has a question or comment?
It's a statement. I don't know where this echo is coming from. Shelley just saw online that the governor had asked Mdhhs to extend the work from home order for another 6 months. So when they publish that later this week, the whole thing should be extended the way it was.
If I may speak to that, so what I did read, and I think I mentioned that earlier, that it's been extended 6 months. It has not been published yet. However, we still do not understand how that will impact meetings held under the OMA. So my OSHA is, from my understanding, the expected order to actually extend the work from home order that was originally issued in October of 2020, and it expires, I believe, April 16th or 15th of this month. Again, that's for work and employment. As it stands right now, the governor has not, and from her public statement that she made last week was that she was not going to issue or require Mdhhs to issue an order that would limit businesses, and I'm assuming we fall within that realm of orders, right, that wouldn't require us to limit our capacity and our operations right now. The urging, but not the requirement, has not come into place yet, and I have not seen anything to the contrary.
Thank you. Mr. Landsman?
Hi, sorry about that. I couldn't get off mute. So even with our overflows, what is our capacity at this point of all attendees?
I believe it's close to 75 with both rooms for overflow.
Okay.
And I could be mistaken. I'm going to pass that to Diana. Turn on your mic.
Thank you, Kalana. Thank you for the reminder on the button. We would probably, between both of them, be about almost 100.
Okay.
And we actually have another room that we could use if necessary.
All right. And then if they wanted to have public comment, they would come to the main room to do public comment?
Nope, what we had talked about is that we will have teams up and running, and as well as a microphone in the overflow rooms, and those will be staffed, and someone would be able to help facilitate that public comment so that someone would not have to move to another room.
Okay. Thank you. That was it on my questions.
Thank you, Kalana. I know it's a lot to keep up with because I think things change day to day, so I'm sure you're very busy. We appreciate your expertise in keeping us updated. one thing I do want to ask, it kind of goes along with this, I was debating whether to talk about it in other business or now, but just the configuration, so when we have our next board meeting tonight, I know we have, I think I counted, there's like 13, I don't know how many desks are set up, 1, 2, 3, like 10 desks set up, so if additional board members were to come in, I think it's gonna get kind of tight. I mean, I don't know what the thoughts are, but maybe trying to think of configuring, because I know it's kind of hard to see one another, keep an eye on the
That's
screen.
why it really helps, this is Sheila, sorry. That's why it really helps for the pre-notice, because it allows me to set up the room, according to RSVP, you know, as far as board members and our reporting staff.
Thank you. Yeah, so just the importance of letting Sheila know, but if we were to have, let's say, full board, I mean, I don't know if it's even a possibility, but if all of the board members, all the chiefs are here, what is the thought on logistically, how would that look?
Well, this is set up for 12, so all board members would be like right here, and then, actually, we were speaking about this earlier, we'd probably do a row right here, for any presenting staff, or maybe ask some staff to, present remotely, if we can't accommodate, you know what I mean? So,
Okay, thank you. All right. Any other questions or comments on this topic? Not seeing any, so we're going to move to other business. Jonathan, discussion on the Policy and Business Operations Committee meeting.
Thank you. This came up in our executive session last week. I think it was last week, where there's been a fair amount of discussion on and off about having a committee of the whole meeting or having a business ops meeting and having a policy committee meeting separate. As you've all noticed, our chairs from policy and from business ops now report out at our monthly board meeting what's going on at their portions of the committee of the whole meeting. And we're trying to do that for a couple of reasons. One is for more of our board to become engaged, because after this last year of being sheltered in place in our caves, we are trying to find a way to get us to be more involved, more engaged. And one of the things that I hate to call them meeting experts, but efficiency experts, I guess is the way to put that, is in terms of meeting effectiveness, especially in a virtual world or in a hybrid world, the efficacy of a meeting goes down dramatically after the meeting crosses 1 to 2 hours. And at 3 hours, it's people are on so many different tangents that there isn't a lot of engagement. So I thought I would bring this up, given that in the last few months, there's been some discussion by folks on our board about, you know, can the meetings be shorter? Can they be more focused? Do they make sense? Should we have separate meetings for policy and business ops, still allowing, so, you know, not have them running concurrently, so that if a board member wanted to attend both, should they do that? And so the purpose of this topic is to have that discussion. And then as well, I heard some other discussion tonight from Hadass and from Eric about other ways that OCHN can energize our board and get us engaged into activities that would be beneficial to the community. So that's why I put it on here. At this point, I'm not looking for a motion. I'm looking for, you know, a round robin discussion of those that may have an opinion or no opinion on this topic. So if there's anyone would like to start this off, and I'll try to, you know, watch the clock and, you know, and make sure that people don't repeat things.
Mr. Lindemeyer?
Hi, thanks for having this on the agenda, Jonathan. And when I first came onto the board, I really felt like the committee of the whole meeting and the board meeting, in a lot of senses, were the same meeting. And so it did come to my mind, why don't we have separate meetings for the policy committee and for the business operations committee? because we may be able to, through separate meetings, you know, I really did tend to get distracted being online for, you know, several hours. My efficiency certainly declined after the second hour. And so there may be an opportunity for us to improve our service to the community by meeting separately. But I also think that as we are moving back more into in-person meetings, that it may take me maybe a few meetings to understand, you know, was my efficiency in the meeting because I was at home and online and I was easily distracted? Or, you know, what was that reason? And so I do think it's worth thinking about and talking about. If we do it, I think that there should be principles about why we are doing separate meetings, having a deeper dive and getting people on the board more active on their committees should be a main principle. There's always a concern that are we going to have two different meetings, and does that mean that there is substantially more work for the staff as a result? And we should be sensitive to the additional work. And so if the board, you know, if we're going to just have two separate meetings, just to have two separate meetings, then that creates additional work for the staff. Doesn't really make sense. But if that additional work that we're going to require of the staff by having two separate meetings, we should make sure that the board in those separate meetings are doing the work in a way that respects the additional work that the staff has to go into, because there's preparation work and there's an attending of an additional meeting potentially, depending on, you know, how we would format the two meetings, if they would be on the same day back to back, or would they be on separate days, et cetera. So those are just some of my initial thoughts. Thank you.
Sarah, yeah, I would agree that I think it presents itself, separating the meetings does present the issue of additional time for staff, additional work, preparing the meetings, and I think it's a lot, even as board members, I know I want to keep current in both of those areas, and it adds then another meeting to attend, which, you know, can be very time consuming. And so I worry about the extra burden that we potentially are placing on the staff and ourselves. I think in the last several months with the committee of the whole, we've become much more focused, and I think, you know, being able to kind of formulate the agendas in a way that it is more focused, and we are able to adjust both of those areas within one meeting. So, you know, I know was talk about, you know, if this was to separate, possibly doing two meetings in the same day, kind of back to back, and to me, that just doesn't necessarily make sense, because I think we're able to adjust it well as long as the agenda is formulated as such. Thank you. Mr. Torres.
I'll just weigh in. So this is a topic that, at least the last 2 years that I've been on the board, that we've revisited, I think, annually and kind of looked at. I was on the board, for those of you who aren't, we have a lot of new board members, back in 2009 for a few years, 2009 and 2011. In that time, we had two separate meetings. We had the policy meeting, and then we had the business ops meeting. And each one was about an hour and a half, and I think we staggered them, or we separated them 3 to 4:30, and then 4:30 to 6, somewhere along those lines. But I remember, you know, being on the business ops meeting, that I always had the opportunity, if I wanted to go to the policy meeting, and vice versa. I liked it that way, and one of the things that, to me, when I came back a year and a half, 2 years ago to the board, it was the first thing that I noticed was the committee of the whole, that we had a committee of the whole instead of having two separate committees, and how long the meetings were. It was one of the things that really, that I saw right off the bat, and I did hear from several board members who talked about trying to separate it. At the time, I know, and it seems to be that the board seems pretty divided on it, kind of a 50-50 split. It's probably somewhere along those lines right now. But I get the portion. There's two good points I think that are made. Jonathan talks about getting the board more engaged in understanding and really getting down into things. And I felt like when I was on business ops, that was a benefit of having that hour and a half meeting. We would have our finance director come and speak and present at that meeting. And then if I wanted to know more about the policy meeting, that I could go to that meeting as well and pick up that information if it fit my schedule or how it was working. So I really liked it back the other way. I would be in favor of the other way. Now, when we talk about the time to the staff, I think we gauge that against, the fact that how engaged do we want to be as a board, too. And then thirdly, I guess I would ask the staff, would it be that much more burdensome to do it, to have two separate meetings? Because the way I remember it, and this goes back, 12, 13 years ago now, was that our finance director didn't come to policy unless there was something specific. They just went to that one meeting. So it was an hour and a half of their day. And the same thing with something that was related to policy. They would come to that meeting and present only at that meeting. And then it would be the job of that committee chair to report back, like we do at the board meetings, what had occurred on that. Or if somebody was particularly interested, they could go and sit in on that meeting and watch that meeting and participate that way as well. So I would say, maybe Dana can enlighten us on that, or and tell us, would it be that much more burdensome to staff if we separated those meetings?
I'll say when I took my mask. Sorry. I'll say when I started with OCHN back in August, I noticed that when you had the cow, there were two distinct sections of that, and that seemed to work well. What I saw as an issue was that if somebody missed a portion of the meeting, at the general meeting, then people had to represent the entire thing over again. So people weren't getting all of the information in one setting. So even if you had it separated out within the cow, and people had given full presentations that will go on the consent agenda now, you found more questions from the board members during the general meeting. So in terms of time, it takes a little more time from staff in terms of when you would actually separate those meetings out. Would it be a same day, or would it be two separate days or occasions? And I think that in doing that, it takes more time away from the day-to-day things that they would have to do. So I would say keep it the same, and what we've been doing is working with the agenda so that they're consecutive. So you start with the business ops, finance portion of the meeting, and then there's no real break, of course, but then you are also doing the policy and program meeting. So I'm thinking that if we were to keep it pretty much the same, I don't know if it's allowable for us to only have that committee member be present for a section of, so if we did it today, you would show up for the first or the second part, depending on what committee you're actually on. So if we're looking at doing it that way, then it's pretty much the same. It would just depend on who would attend at what time of the day for that meeting. And there wouldn't be a big gap in between the two. So.
Thank you. Any comments from those attending remotely? Or, Melchiah. I didn't see Melchiah's hand, and then I'll come to remote. Sorry.
Thank you, Sarah. I hear what Jonathan is saying about wanting to energize the board. But I also look at the fact that the majority of this board is new and has very little understanding of what OCHN does. When we were in the split meetings before, we had a core group of board members that had been there that could educate the other new board members as they came along. Most of us are new. And I think it would do the newer board members a greater disservice to split the meetings, because the information that we receive in the combined meeting is both the operations and policy at the same time. If people have questions, they can ask questions, and the full board would get the benefit of those answers. That was one of the things that really made it difficult when we split the meetings before, because you had to attend 2 meetings in order to get the full understanding of what the policy side of the business was and the business side of the business was. I don't think it's the issue of the meetings so much as how we utilize our time. We have a 3-hour block for the committee of the whole. I think we need to be real strategic about how much information we schedule in to that 3-hour block. There have been some meetings that have been unbelievably long. And whether we were here or at home, it was just too much information to assimilate in that block of time. And we keep forgetting or ignoring the fact that we have our study session as an additional meeting where we could come together and get additional education on topics that people may need. But I saw the wear and tear it did on the staff when we had the 2 separate meetings. Even though finance director may not have attended both meetings, there was still some staff that had to be present at both meetings. Some of the staff would start at 8 o'clock in the morning, and some of them had to work till 8 o'clock at night. I don't want to see us do that to them, just so that we can separate the group, when, to me, I don't see the benefit in it. Not right now. We're in a building pattern, an education pattern. I've forgotten how many people we have on this board that don't even have a year in under their belt. And we just got another new board member today. I think it would do a grave disservice to the board members to separate the COW meeting at this time. I don't think you're going to energize us anymore by adding another meeting when you can energize us in this meeting. Be strategic about the information you provide and utilize the study sessions well. We don't even use it half the time. If you want to add more, because when we add anything, we add more obligation and to the staff. Some of them are going to have to be here to be with us, because all of us don't know the information. And I appreciate the committee chairs giving their report, but we only have a 2-hour meeting for the main meeting. And to go over what was already said in the committee of a whole in that 2-hour meeting, to me, is a disservice, because there's other things we could be discussing that haven't been heard. I don't want to see us rehashing the same information over and over again when we have too many new people that we really need to educate and bring them up to speed. Because if you think about it, we're together 24 times a year. That's a huge learning curve to try to understand just the budget alone. We're not even going to talk about programs. This is a huge system, and it's changing we're getting ready to go through another onslaught with system redesign. There's so much that's going on. We can't afford for everybody not to know what's going on. And if we split it, somebody's going to get left behind, I guarantee you.
Thank you. I see Dr. Taub and then Mr. Furman.
Okay, following up on what John Paul said, when we had two separate meetings, the CFO had to report the main report, the financial report, to both committees. So one of the reasons that we put the meetings consecutively on the same day was we'd have the business ops meeting, then the two meetings would overlap for a half hour while the CFO gave the report to both committees, and then they would get to leave. Then we'd go on to the policy committee. So I've been a strong supporter to have two separate meetings. It worked well when we did it. I've been on the board 18 years. It worked well, and one of the reasons we went to having the two committees meet consecutively was so the CFO didn't have to report the same report to both committees. Then it went from there to just one committee. So, and as was said before, the board's pretty evenly divided. Every time we bring it up for a vote to either combine them or separate them, there's like a one vote difference. So everybody has their reasons, and I agree. I think it would be better to have two committees and then at the board meeting have a summary of what happened, and you can get it from if you didn't attend the other committee, you could get the summary. And if you wanted to know more, you could attend both committees. Most people did not attend both committees. So that's all I have to say on the subject.
Thank you. Mr. Furman?
Yes, for me, I'd just like to echo, I think, what Sarah and Dana mentioned in terms of agenda construction, especially as it relates to both the committee of the whole and the board meetings. I think for anecdotally about the last 8 months, we haven't gone much further over the 2-hour mark in the committee of the whole meeting. So I really think we have been more efficient in that regard. And as long as we continue along that route, I think we'll be fine. So that's pretty much all I had.
Thank you. Any other board members remotely that wanted to provide comment?
So Sarah.
I'm not seeing any hands, Jonathan.
Thank you. So I just wanted to respond on a couple of comments that Melchiah made. So one is the study sessions. As you all know, I've been itching to get us into orientation and getting us tooled up to know how to use the tools, understand the organization, understand what our mission is, and understand how things are of what's the right word? Evolving. Some of it good, some of it bad, as you've heard with the redesigns. And the other news recently about the child of 298, if you will. So I'm glad at the end of this month, we will have our study session. It will be on orientation. It will be to help our board understand the ins and outs, and it's a start. We couldn't do it in February, couldn't do it in March. We'll do it in April. So we are behind the ball from that standpoint, only because the state is energizing to change who does what, and it doesn't look pretty from a standpoint of it. The managed care organizations want to take it over again. Not a surprise. So we have to find a way to not just defend, but to go on the offensive to say, what more can we do? What more can not just Oakland, but all the CMHs and IHPs do? The other question that kept coming up in years past was, what's the purpose of having two committees other than it's in the bylaws and I think in the mental health code if we only meet as a giant committee? So, and I won't have a diatribe on that topic. Because I also happen to have both business and policy or that I like. So, but again, with the full board, I wanted to bring it up, have the discussion. I wasn't looking for a motion, certainly not tonight. I wasn't looking for a motion for next Tuesday, unless there were very strong feelings and they, that they were, and most of them outweighed the keeping of the cow. The other is, Dana, I know you came from Detroit Wayne, and there, as with a lot of other CMHs, they do have separate meetings. And I wondered if you could add a couple of minutes about how that works, why it works well or why it doesn't, if that's
In
okay.
Detroit Wayne, they actually had 3 board meetings, with actually 4, and the board study sessions occurred quarterly, if that. They had at least 2 board study sessions a year, and they were pretty much all-day board study sessions. All of their board meetings were during the day. So that was another thing, was a part of the working day, which I think staff would appreciate. That's just a side note. But the other board meetings that they had were, the first Wednesday of the month was the Finance Committee meeting, in which the CFO actually facilitated the information, and there was a board chair for that committee. And the second Wednesday of the month was the Program Compliance Committee meeting, and the COO actually facilitated the information in that meeting, and that was, like I said, every second Wednesday of the month, and they were 2 hours long, each of these meetings. And then the third week of the month, they had an executive committee meeting, which was on the Monday, and then they had what they called a full board meeting. So everybody from the committee meetings would show up at the full board meeting, and they would pretty much, the board ran the entire meeting with the CEO giving a report at the end. So they had done this, like we said before, a long time. So I think people get caught up in the historical way of doing things. But I think I would say look at what's best for OCHN, knowing the challenges that we have to work on, but also aligning with what the priorities are for the state, which we should be aligning with. So in saying that, I know the finances are very important, and I also know what we're doing for programming and compliance are critical to our mission as well. So I don't have a particular way to say whether we should do it one day or the way Detroit Wayne did it, but I do think in terms of using our time effectively, I know people get tired after 2-hour, 3-hour meetings, but using our time effectively, I think since I've been here, I've seen some improvements in terms of our agendas being really set and the information being ready and prepared and staff being available to answer any questions that occur. I know have heard also consistently that there is a desire of several board members to be more involved in advocating for the people we serve. And I think utilizing those other committees, such as the SUD Policy Oversight Committee, as well as, or the board, the Recipient Rights Advisory Council and the Citizens Advisory Council are great opportunities for our board members to get more involved and also to advocate. So the other thing I would say is that we can do another thing for the board in terms of offering up talking points so that you know what are the things that we're faced with, and then also some of the things that you can do to help educate the community and advocate when you're talking to legislators. So that's pretty much, I mean, it worked that way for Detroit Wayne because that's how they did it for years and years and years. So I think it's just a matter of managing the agenda.
Thank you. And again, my purpose here was only to raise the topic. I am not looking to have a motion. I'm not going to suggest a motion. So, and thank you for sharing what went on in Detroit. So one other aspect you raised is that they met during the day, and I know that maybe 60, 70% of our board, 7, 8 people, have day jobs, so I know that would be very difficult for our board. So I'll leave it at that. If there's no other comments, I'll turn it back over to you, Sarah.
I had one,
You know
one
what?
quick comment.
Oh,
And
John.
then I have a comment too.
Oh, Hadass?
Well, just the comment, and this is always, just for discussion, what Dana talked about, they had, a separate finance committee, a separate program compliance committee, in that the point is that you can go in deeper on a particular topic, which we don't really go into deeper on those particular two topics. What we've done is, yes, we've made the agendas so that the timing is shorter, which is great. But on the other hand, we're not really delving into certain particular topics. Like we said, we haven't had board studies, so maybe we did. But that finance and program compliance is really ongoing. It's not really a board study, I don't think. So there's pros and cons. And then the other thing is, it's always very, very difficult to focus, for 2 hours. And everybody's very, very busy during the day. But, I've been on different boards where you do, an 8 to 9 meeting, or even if it's a 45-minute during lunch where you eat your lunch, once a month during the day. It's not that, at least I found once a month, that it can be during lunchtime, a 45-minute meeting. If we did end up separating anything, it wasn't too crazy. Dana talked about staff, and we keep talking about the staff. The staff does not need to attend every meeting. That came, my understanding, from 2 CEOs ago. So, it's just the particular staff that's there for that particular meeting, so it shouldn't extend staff time. On the other hand, I understand, it's a pandemic, we've got so much to learn. So I don't know, my opinion is you can go either way, and I just felt I wanted to, make some comments. But I appreciate the discussion, so thank you.
Thank you. Mr. Torres?
And just one last comment. Agreeing with what Hadass was saying, it does allow us to delve a little bit more, a lot more, into our particular area, whether it's policy or business operations, and become specialists in that particular arena. So we're taking on less and being able to get more into that, rather than taking on a larger plate and being okay and understanding, or just having a comprehension rather than having a strong understanding, is the way I look at it. But I would say, I would say we do have new board members. We got to, I know Jonathan wants to get this orientation. Let's allow some time to sit with board members to kind of get their bearings a little bit. And then maybe, we try a pilot for a month. We pilot it for a month and see if it works, what seems good, what doesn't, with really no commitment that we're going to continue that, but try it out a little bit to see if there's anything to gain from it, and then, then move forward with the decision at some point, or a vote before the board on the issue. Thank you.
And just a follow-up, and then Melchiah's hand was up. I think in terms of folks saying that they want to delve deeper into some of these topics, is the executive committee now meets, is it the first? I forget which day.
First Wednesday at noon.
First Wednesday at noon. And so if there are topics, I would encourage folks to come to that meeting, because it is a public meeting, to discuss some of those topics that want to be, delved into deeper, so that we can incorporate that into the agenda planning. Melchiah.
That's basically the comment that I wanted to make before we make any changes to accommodate people that want a deeper dive. I think they need to bring those topics forward, let it be known what it is that they want more information on, because one of the things that this staff has consistently done is try to accommodate the board and give them the information that they need to govern effectively. So if you're not getting the information now, you need to let it be known to Dana, so that Dana can provide that to the board. But just to say, I want a deeper dive, that's not really giving them any information as to what you're missing in terms of information. They need to know that so that they can get you the information you're looking for.
I'll do case in point on that in support of what Mdhhs just said. There were a handful of questions regarding finance and the budget amendment total. Nothing on finance actually this year or on this month. And that just says that the presentation materials are now presenting, and there's an echo, so I apologize for my delay. But the materials are being presented in a way that makes it easy for our board members to consume it with what they want to know. So that's an excellent example of what Mdhhs was saying.
Sarah, may I
I'm
add?
sorry. Go
I'm
ahead,
sorry.
Dana.
Oh, I'm sorry.
No, but Jonathan, I don't know that you can really make that assessment because there were no questions. Because when I first came to the board, I was terrified. I didn't want to ask questions because I was ignorant, and I didn't want to show my ignorance in front of all these learned people that I was sitting with. So before I make an assumption that everybody understood this presentation that we got today, my assumption would be because we have so many new people sitting around this table, they don't even know what question to ask, which is another reason why I'm saying this is not a good time to split us up.
Okay, Dina, if I could just add, I serve at the pleasure of this board for sure, and I do want to make one recommendation. I forgot to mention this, and one of the things that in Detroit Wayne that they started to do in the last few years was at each end of board meetings, they would do a list of action items. So I've heard Hadass ask for information. That would be an action item. I've heard Dr. Hans ask for clarification on self-determination. So I take notes, and I know those are things that we need to follow up on. So maybe I would recommend as a board and as a committee meetings are ending, we review what are the action items that we need to bring forth at the next board or committee meeting. And then that way people feel like, even if I don't know what questions I want to ask, I want more information on it. And then us or the team of staff, we know what items we need to follow up on and make sure we come back to in the next meeting. Even if we don't formally present the information, we can have the information at least in a written format so you can have that follow-up.
Okay, any last minute comments or questions on this topic? All right, well, thank you, Jonathan, for bringing this for discussion. And we'll continue to have further discussion and see how things go, it sounds like, so. All right, Christine, is there any public comment?
No, we did not have public comment this evening.
Okay, and we have no one here. I'll turn it over to Sheila, but no one.
Yeah, there's nobody here, so we're good.
Okay, so we'll move on to board member comments. Sheila, if you can call the roll, please.
Mr. Cohen?
No comment. Okay.
Dr. Hans?
I have no comments.
Ms. Newman?
No comments.
Dr. Taub?
Hi, I've just got a couple of things. They're mostly questions for Sheila. One question is, when I went to Boardable for this meeting, I did not see an agenda to print out. Since I'm doing this on my phone, not having a microphone or camera on my computer, I like to print out the agenda so I can, it's big enough to read. So in the future, could we please have, the agenda? We always have before. I don't know, things got changed around this month. Maybe the agenda didn't go along with it. And secondly, if the herd immunity gets up enough that I think it's safe medically to go to the meetings, I'm considering future attending in person. I assume we're not going to be serving any food like we did in the past for the board meetings and the study sessions. Is that correct? Sheila, could
For
you-
board meetings, I'm not sure about the agenda. I'll check into that, because you should have received an attachment in the email that I thought it was attached. And it's in Boardable, so I'll check in to see, maybe you have it. People are shaking their head in the room that they had it, so I'll see if
Okay.
you had an issue. And then as far as meals, I'm going to do boxed lunches. That's again, another reason why it's critical, or boxed meals, why it's critical to have board member attendance. So I can provide that at board meetings.
would that be eaten in a little conference room, or would that be eaten right in the room we're gonna have the meeting in?
We're gonna have a separate room for it. So
Okay.
again, we'll serve it about 5:15. We'll start serving 5:15 to 6, and then you'll move into the board meeting room for the meeting itself, in the Michigan room. So
Thanks
we'll
for
make.
the answers. I have one more comment. I think the echo we're getting is because it's echoing on the mics in the room when we're speaking. Well, the echo went away, so now we fixed it. But speaking of herd immunity, you know the story of Noah and the ark. Just remember what Noah said. Now I heard everything. That's all I have.
Mr. Lindemeyer?
Hi, yesterday, what's today, Monday? Yeah, yesterday I was at a Stop Asian Hate rally at City Hall in Troy. And we have seen a rise in Asian hate crimes, and I think that it's important for us to recognize it and understand it. To be honest, I was a little disappointed because 95% of the crowd were people of color. And as a white male, I think that it's important on our entire community to understand that we must speak out against any Asian hate that we come across, and that we talk to our neighbors about being sensitive to everybody in our community. Thank you.
Ms. Root?
No comments, thank you.
Mr. Landsman?
Thank you. I just wanted to bring up a couple of things. Even though some of us are still in our caves, I just thought I would bring this up in case anyone didn't know it. And Dana and the team, leadership team, kudos to you guys. OCHN was one of 2 PIHPs that were selected for the MyCal, the Michigan Crisis Action Line. So it launches later this week, early next week. Anyhow, just question, maybe we can have something that explains a little bit more about what this pilot is, and how we're participating in it at one of our upcoming meetings. Nothing big, just something to help people get some visibility on it. Because again, we're one of 2 PIHPs that were selected. The other is, I know that there was a state interim settlement on child behavioral health. And I wondered if, with that litigation settlement that the state has to do, if they're going to be looking for a partner or 2 that can help them deploy that additional services and supports to child behavioral health. So that might be something we want to look into. So, and then last thing, just because we haven't had study sessions for the last couple of months because we've been waiting for the full board reappointment or appointment, mark your calendars. Thursday the 29th is study session for orientation. That's it. Thank you all. Thank you everyone out in the field who's helping the people we serve. Thank you to the leadership and the staff working remotely, but are part of this OCHN team, helping the others help themselves. So again, thanks.
Mr. Furman?
I just really wanted to thank the staff for the presentations tonight. They were very informative. I also like the fact that I think we mentioned it in previous meetings, but the fact that we got kind of an informal, impromptu discussion on the topic of self-determination, how it's implemented in on the developmental disability side, and then maybe how the people that experience mental health challenges may look at that a bit differently. So that I thought that informal discussion tonight was really helpful. So thank you very much, and be safe, everyone. Take care.
Ms. Bernard?
I want to thank everybody and staff for a very good meeting. I think it's great that we're able to talk about so many items. I've been on this board for now 2 years, and I've seen tremendous growth in the board as a board to be able to listen and, just respect everyone. So I wanted to thank the board and also the staff for that. I really thought Dana's idea of action item was really great, and so maybe we can add that to the agenda, every agenda, I don't know, or which specific agenda. And then lastly, I want to thank Eric for bringing up his conversation about the Asian Americans. I think the diversity, equity, and inclusion is something that we should always keep in mind on this board. I think we do, but it maybe needs to be brought up, continuously, because that's always something for improvement. So thank you, everybody. Have a good night.
Ms. Naming Dyer?
No comment other than to say it's good to be back after being out for 2 months. So thank you.
Mr. Torres?
Well, I just want to say the in-person meeting was nice. It's been a year, but I did worry and teetered back and forth about whether coming because of the numbers being so high and all of the risks that are posed. So I'm half vaccinated. I'm still waiting for my next one in a couple of weeks. So just encouraging everybody to get vaccinated. I don't think that I can remember a time in this pandemic that I have known so many people that have gotten COVID, have gotten sick from COVID, and have died from COVID. So it is probably the scariest time right now for me personally since really the first few weeks of the pandemic last year. So just encouraging people to get vaccinated, particularly communities of color, those in the African American community and the Latino community. There's a real struggle with people getting vaccinated as well, as far as their approach towards it and the fears that they have from it. So, but it is nice to be here in person and to be able to interact at some level with social distance with everybody, and the format with those online being able to participate in the discussion. Thank you.
Dr. Guadalupe? I just want to echo everyone else's sentiments towards the staff, so thank you all for the great presentations and for supporting the board, because I know many of you have to be in for the meeting to be here in person to support us, so I appreciate your time and being here. And I thought there was great discussions tonight, so everyone stay safe. Thank you. That was it. The meeting is now adjourned. Everyone have a good night. Take care.
Good night, everyone.